Yes.
All right, so today I want to introduce percutaneous hepatic perfusion, kind of a newer procedure in the realm of IR. This is by no means meant to be a comprehensive review, just something to get your feet wet and learn a little bit about why this came to be and where we're headed. I'm going to focus on uveal melanoma, the application for uveal melanoma, just as that is the currently the only FDA-approved indication for this. All right, so uveal melanoma is the most common primary intraocular malignancy in adults. It can arise from either the anterior or posterior portion of the eye, with the vast majority of cases arising posteriorly from the choroid. About half of all patients will develop metastatic disease at some point during their disease progression, and 90% of those will have liver involvement. Having metastatic disease in the setting of uveal melanoma portends a very poor prognosis. Survival is just 12 months from the time of diagnosis. So definitely something that needs to be addressed for this orphan disease. The progress that we've made in cutaneous melanoma in terms of immunotherapy, systemic therapies, has really not been mirrored by are you still able to see my screen?
Yeah.
Screen.
There we go. All right, it has not been mirrored by those made in cutaneous melanoma. So actually, it wasn't until 2022 that the first systemic therapy was approved for uveal melanoma, and that was tebentafusp. Following that, it was Hepzato, which is the brand name for the PHP, or percutaneous hepatic perfusion. So really, many decades of really no adequate treatment for these patients. You can see here that a lot of the drugs that worked for cutaneous melanoma showed abysmal response rates in the setting of uveal melanoma. So you see overall response rates in the single digits, sometimes low teens at best, for drugs like Pembro, Ipi, Nivo, atezolizumab, dacarbazine. All these showed very good response rates in cutaneous, but because the mechanisms behind these two diseases are fairly different, despite being termed melanoma, we didn't see that mirror over into the uveal melanoma realm. Back in the 1960s, a surgeon up in New York described a technique called isolated hepatic perfusion. This was an open surgical technique in which you cannulated the hepatic artery, portal vein, isolated the perihepatic vena cava, and basically infused sometimes hyperthermic chemotherapy directly into the liver. This was meant as a salvage for metastatic disease, predominantly for sarcoma and melanoma patients at that time. It was a very involved procedure, something that could only be done once, and carried a pretty significant morbidity and sometimes mortality. Later on in the evolution of that surgical procedure, the Scandium trial came out and kind of demonstrated for the first time in a trial setting that the procedure did actually work. The overall response rate was significantly higher for the IHP group compared to the control group, as was the progression-free survival. The overall survival benefit was not yet clearly seen, but you can see there the serious adverse events was pretty significant. About 20% of patients had significant adverse events and required hospitalization for multiple weeks after this procedure. The the progression-free survival you can see here being significantly improved in the IHP versus the control group. And then the decrease in tumor size on the left, you see those who received IHP had a significant decrease in size of their tumors, whereas the majority of patients who were in the control group increased in size. So the natural evolution of this procedure was to have a minimally invasive alternative, and that's where percutaneous hepatic perfusion came in. The main indications are not significantly different from those of other local regional therapies. You want mets involving less than 50% of the liver, so they should still have some intact synthetic liver function. There should be liver-dominant metastatic disease. Extrahepatic disease should be limited to lymph nodes, subcutaneous tissue, bone, or lung, something that can be managed with another therapy, even surgical. Contraindications, uncorrectable coagulopathy, brain mets, recent liver surgery, liver failure, allergy to the drug that we use, or things precluding general anesthesia. Melphalan is a nitrogen mustard agent. You may have heard this being used for myeloablative regimens prior to bone marrow transplantation. It's still used for that purpose to this day, but this is the workhorse of percutaneous hepatic perfusion. The technique can conceptually be described in three main phases: isolation of the hepatic perfusion, perfusion of the drug, and then filtration of the drug prior to returning to systemic circulation. The technique overall involves multiple points of vascular access. We typically access both internal jugular veins, one to provide anesthesia use, the other to return the filtered blood, and then two groin accesses, one in the common femoral vein, one in the common femoral artery. The common femoral artery being used to actually cannulate the hepatic artery and then infuse the melphalan, and the common femoral vein being used to get the efflux of the hepatic venous outflow, run it through the filters, and then return it to the IJ. As soon as we get all our access, we heparinize the patient to an ACT greater than 400 and then select our first target hepatic artery. This is a picture of the double balloon catheter. You can see the two components. It has 5 lumens, one to inflate each balloon, one to access the fenestrated segment you see there in the middle in between the two balloons, and then one to run over the wire over here. The other one accesses the fenestrated segment as well to inject contrast. So the top balloon sits at the inferior cavoatrial junction, and the inferior balloon sits above the renal veins. This is a schematic or a picture of the filter itself. It's a double carbon-based filter that runs in parallel rather than series. And you can see here from the phase 1 and 2 trials that the systemic concentration of melphalan is significantly lower, pre-filter being the top line, post-filter being the middle line, and the lowest line being the actual systemic levels. The efficiency is greater than 85%. Actual real-world usage is greater than 90% in the animal models. After we inflate the balloons, we confirm that we've isolated the perihepatic inferior vena cava by injecting contrast in the fenestrated segment. And this is exactly the picture you want to see. So the top balloon assumes this acorn type shape. The bottom balloon is above the renal veins, and you see contrast stuck between these two balloons, not extending into the right atrium or below into the renal veins or other parts of the cava. Once you inflate this balloon, you open the filter sequentially to saturate the carbon and activate the carbon-based filter, and then you clamp the bypass line, at which point you see pretty significant hemodynamic shifts in the patient's blood pressure. You manage that with a very significant dose of vasopressors, typically norepinephrine, sometimes vasopressin, depending on how the patient's doing. And then once they kind of stabilize to being having delayed venous return, you proceed with the infusion. You'll assess for hepatic arterial vasospasm, infuse the drug. Typically, we do a third on the left and 2/3 on the right, and then you'll repeat it for the target hepatic arteries. So this is typically done in lobar fashion and not for targeted segmental lesions. After that, you wash out for about 30 minutes to get whatever you can out of the blood, and then take out all your accesses after the coagulopathy has been corrected. There are 2 phase 3 trials that kind of both together led to FDA approval. The first one was not sufficient because there was trouble accruing for the best alternative care arm. You can see that there was a good signal from perspective of the hepatic progression-free survival and the overall progression-free survival, along with the response rate, but not so great on the median overall survival. This did allow crossover, but there was a trend towards improved survival. The main side effects of this therapy are hematologic in origin, so anemia, thrombocytopenia, neutropenia, all of which can be managed very easily for the most part. Much like the Scandium trial, we saw pretty significant decreases in tumor size for the patients who underwent treatment, increases in size for patients who were in the best alternative care arm. This was followed by the second phase 3 trial, which was a single arm trial. The reason this was made a single arm trial is because this therapy was actually approved for use in Europe much earlier than it was in the US. And patients, knowing that it had a good response rate, were not really willing to undergo randomization and possibly not receive this therapy for what is otherwise a pretty fatal disease. The results of this trial were pretty convincing. Overall response rate was significantly higher in PHP versus best alternative care. Overall survival ended up being around 36%. Overall response was 36%. Progression-free survival was 9 months, and median overall survival was 20.5 months at the time the data was published, and the final analysis is still underway. This is an example of a patient who we treated back in 2019, had multifocal metastases from uveal melanoma. You can see on the diffusion-weighted imaging, the three images on top are pre-treatment, and after 6 sequential PHPs over the course of about 6 months, you can see they actually no longer have any disease and are still alive and doing well. Recently at ESMO last year, a combination trial was actually published, which showed even more remarkable results compared to PHP alone. So they combined PHP with ipi-nivo, kind of maintenance therapy, as well as prior to the first PHP. The overall response rate was pretty significant. 76% of patients responded in the combination arm compared to 39.5% in the PHP only arm. The progression-free survival was also improved, 12.8 versus 8.3 months, and the overall survival, 23 months versus 19.6 months, all statistically significant. So where do we go from here? Are there other tumor types this can apply to? There are trials underway which will be have started or will be starting shortly, looking at breast cancer and colorectal cancer, third-line settings to second-line settings for both of those. Can we do sequencing and combination therapies? So we mentioned Chopin trial. The final analysis is going to be published later this year, but we're excited to see that and see it integrated into daily practice for uveal melanoma. And then timing, patient selection, prognostication. Who are the right patients who will benefit from this? When should we time this therapy? Should it be before other systemic therapies, after, in combination with? Those are still questions that remain to be answered. Then also some non-oncologic applications. Where else can we apply this therapy? Could this be something we consider for metabolic liver disease? Are there applications in that? And I think that's a pretty exciting avenue for the future as well. Thank you for your time.
Thank you, Dr. Ahmed. Does anybody have any questions? Feel free to use the chat. I have a question. So, in general, and you use an example of a patient who received 6 treatments. What are some of the criteria that you're using to determine how many treatments a patient's getting, how far apart they're spaced?
That's a great question. So typically the standard for both of the trials was 8 weeks between each treatment. And the way we determine whether we keep going or not is as long as they don't have progression. So stable disease to response, any kind of response means you keep going to up to 6. And now we're actually, since commercialization in 2023, actually, we just treated our first patient for their 7th PHP about 2 or 3 months ago. And they're going to get their 8th PHP here in the next month.
Are you seeing any of the hepatocytes? Are you doing like biopsies of the normal liver to see if there's any impact, or fibroscans, something of that nature, to see what the impact is on the normal hepatocytes?
That's a really good question, and that's something that hasn't been published yet, but we're actually presenting it at the Society of Surgical Oncology this year that shows no significant chronic effects. Now, we have not done biopsies itself or fibroscans to prove that, but this is based on just laboratory function. So typically what you see is a bump in liver function tests, most often the transaminases, less often the bilirubin itself, for about 2 to 3 days, and then they normalize within the first week. And then by the time the next PHP comes around, 95% plus of patients are at a normal baseline of liver function tests.
We have a question in the chat from Martin, and he asks, what is the usual next steps for non-responders after failure of treatment?
Usual next step, that has changed recently. So tebentafusp was one systemic therapy that I mentioned earlier, and that is actually HLA specific. So about 40% of patients will be HLA-O2/O1 positive, who are the subset of patients that actually respond to this novel immunotype therapy. So that is one option if they have the correct HLA type. The other patients will typically go on to one of those other combinations, ipi-nivo, or Nivo alone, and the response rates aren't great, but that's typically all we have right now. There are some other things in the pipeline that are kind of coming up and look very promising, though.
And I think we have time for one more question that was asked in the chat. How do you consider treatments like immunoembo with IL-2 or GM-CSF before PHP, or do you usually go for PHP first?
There's not a lot of data regarding the combination of those therapies. So immunoembolization is an interesting concept. Some centers, namely Thomas Jefferson, are very strong in incorporating that into their treatment algorithm. The data hasn't really borne out to make it widely used. But overall, the other component of your question is that we consider a PHP first strategy for most patients. When you look at the adverse events that happen with these other therapies and kind of chronic toxicities, immunotherapies, over 30-40% of people will experience some sort of adverse event from this that is usually prolonged. Autoimmune hepatitis can happen with ipi-nivo combinations that are actually fairly common, and other kind of quality of life issues. It's very unlikely, given what we know from PHP so far and the lack of chronic hepatic synthetic dysfunction, that we're going to disqualify a patient from one of these other therapies we mentioned. But the contrary is not always true. So many times patients will, just from progression or worsening of liver function or having a poor functional status, will not be a candidate for PHP after undergoing multiple cycles of one of these other therapies. So we tend to prescribe PHP first if the patient is a candidate, and then most often they're still eligible for other therapies should the time come.
Thank you, Dr. Ahmed. Excellent talk, and thank you for answering all those questions. I will now invite Dr. Saad to share his screen and begin his talk on chronic portomesenteric veno-occlusive disease. Welcome, Dr. Saad. Yeah. Dr. Saad, if you're speaking, we can't hear you. Dr. Saad, I believe your mic is muted.
You hear me now?
Yeah.
Okay,
We
good.
can.
Sorry.
Keeping all your pearls to yourself.
Huh?
You're keeping all the pearls to yourself.
Oh. I do not have control over this. Okay, now I do. Sorry about that. So I'm going to talk about briefly about TIPS PVR, mostly technical, just to kind of wrap your head around going transplantic, transhepatic, and transmesenteric. You're seeing different presentations about this subject. The first line for portal vein recanalization is primarily transplantic. That's kind of like been described and very well applied clinically by the Northwestern group as a primary approach. And it's really a first line approach because you can actually pull the tips and the portal venous access towards the spleen and maintain that kind of tips curve towards the spleen. For years, it was a forgotten access to the portal circulation. There were concerns about safety, but I think Riyadh and company have really shown that it is actually relatively safe and reapplied that or reintroduced that access to the portal circulation to the IR mainstream clinical community. The next is a transhepatic access, which is going through the liver and is either a second line or an adjunct to the first line, which is transplantic. And you resort to that as a second line. Either the spleen is non-existent, the spleen is very small, and commonly it's high up in the abdomen where it's a more difficult or transpleural access. Or you do actually get into the splenic vein, but you just cannot find your way from the splenic vein to the portal vein to complete the TIPS PVR, kind of like rendezvous with yourself. And that is more likely to be in non-cirrhotics than cirrhotic patients. Another reason to go, trans hepatic is actually to get into the mesentery when you cannot get to the mesentery from the splenoporal axis, where there's some mesenteric discontinuation. The last line, which is the more invasive line, the least described line, is the transmesenteric axis. And that's either with mesenteric discontinuation or combination of transhepatic and trans tips mesenteric rendezvous. And like I said, it is the least resorted and the most invasive. So here's kind of your kind of typical transplantic access, getting ultrasound guidance to the spleen, usually kind of lower to mid portion of the splenic tributaries, to try to have a direct access to the splenic vein. Here's after ultrasound access, injecting contrast, seeing that kind of splenic tributary, and then passing a wire through transplantically into the main spleen. This is kind of your initial run. And this is very, very typical of a cirrhotic trans PVR. You usually have this very large shunts, in this case, a kind of splenorenal shunt or multiple splenorenal shunts. And this is in, I would say, 90 to 95% at least of cirrhotic patients with TIPS PVR, there is a large shunt. In fact, the shunt is the cause of the portal vein thrombosis. There's something called portosystemic shunt syndrome, where you actually spontaneous portosystemic shunt is created under pressure, and this shunt grows over time. It starts stealing the outflow of the spleen. It then takes over and steals the outflow of the mesentery. It then reverses flow in the portal vein. The portal vein shrinks, the portal vein clots, the portal vein thromboses, and the entire outflow is the shunts. And this is basically, and then they present for a TIPS PVR. So TIPS PVR is the final stages of portosystemic shunt syndrome, which thromboses of the portal vein and a large shunt in at least 95% of cases of TIPS PVR cases in cirrhotics. Here we go. You go across with a snare, and then you kind of land. And this is a difficult TIPS, and they are usually more difficult TIPS than conventional TIPS, because part of portosystemic shunt syndrome is that the portosystemic shunt literally sucks the life out of the liver, and the liver actually progressively becomes smaller and smaller. Doing a TIPS in a small liver is very difficult. This passing needle through the snare, and then you unsheath the wire. This is an 035 wire, and then you basically pull back, and you see this curve, beautiful curve, and this is what you get. It's easier to pull your trans TIPS wire than push transhepatically from the right, and this is why it's the primary approach and not transhepatic approach. Once access is achieved, you basically angioplasty and you put a stent in. Next case is another case where transplantic access is achieved. It's showing you a very, very small liver. Different techniques in trying to access this portal vein in very, very small liver with very short distances. One of these techniques is putting the back end of an Amplatzer wire in the liver and going adjacent to it and poking from the cava directly into the portal vein, almost like a dips, because you don't have much space or much running room to get into the portal vein. And again, you see that beautiful curve because the wire's been pulled from right to left instead of pushed. And there you have it, is basically a TIPS and the beginning of a large shunt that needs to be occluded as well, as we discussed. Next is a transhepatic access to try to get down into the mesentery. And we said it is a second line approach. Either the spleen is non-existent, the spleen is small, very difficult to get to, or you can't get your way into the liver from the splenic side. Another reason is You are able to cross over, but you can't get down to the mesentery. You can't have mesenteric to portal venous continuation. The not common type is spleen is non-existent. That's you can find that in where the surgeon has taken the spleen out over. Uh, you see it more often outside of the United States, but you find patients with splenectomy with these cases. It is having a small spleen up in the abdomen is uncommon in cirrhotics. It is more common in non-cirrhotics, but for cirrhotics, it's quite rare to find a small spleen. And then your last resort, which is what we're going to talk about later, is basically going transmesenteric. But this is the greater scheme of things, and transhepatic is your second line. With mesenteric discontinuation, again, your first line will be transhepatic. You try that out first, and if that fails, you stick the mesenteric vein. You stick the mesenteric vein directly. When do you do mesenteric and portal vein recanalization? If there's variceal bleeding, especially duodenal varices or Roux-en-Y, hepatico-J varices, as a prelude to transplants and portal vein patency issues. With splenomesenteric discontinuation, especially without a spleen or with a small spleen. In some cases of ascites, but that is kind of the last thing because it's usually a high risk, but mostly it's for variceal bleeding and as a prelude to transplants. Here we go with transhepatic access as a patient with a spleen, but you see kind of like portal vein thrombosis there. This is actually chronic portal vein thrombosis. It's all scarred, but you actually see the portal vein. There is a large spleen. We fail to come across from the spleen to the mesentery, and there is mesenteric discontinuation in this patient. So we access transhepatically, finding kind of that portal vein, targeting portal vein branches open and to give us some running to them and put a wire in and just basically fight our way through the liver, going centrally. That's kind of your typical cord of a portal vein occlusion. Try to target that cord to get in there, get down to the mesentery, getting into branches or tributaries, and then we're finding what you're looking for is a normal mesenteric vein look, and to try to get to that normal mesenteric vein so you can actually angioplasty towards and recanalize it. It's kind of like repeat angioplasty. Then you land your tips on your snare, and then you're going to have to basically push your snare. You're not pulling this time, you're pushing, and typically it's not as beautiful as this. Usually it's not as smooth of a curve as this. Is usually a sharper curve. When you're pushing it, deploy your stents, and then shut down some tributaries, not necessarily all tributaries, extend the tips from the hepatic venous end, shut down some shunts to try to force flow through your portal vein that you just recanalized and angioplasty and through your tips. You don't have to shut down all collaterals. You don't have to shut down all tributaries. And over time, it will look better. These patients typically, especially if you don't have splenic access, if you only have mesenteric to tips, you're going to have to bring them back again and again for repeat angioplasties, and they do improve over time. Next, very quickly, is a mesenteric access. This is early on in experience. It's actually an SMA run, looking at the portal venous phase just to see where the mesenteric veins are. You can access by ultrasound as well. That's actually the more common way, but if things are gassed out, this is kind of the old way of doing it. Find the mesenteric veins, find where the normal ones are so you can actually target them, and then access. This is a direct access down with a 21 gauge needle. Do a run. These just collaterals. I can't go through all the details. You're trying to get to the main portal vein through that, but all you're seeing is collaterals. And then what we saw was a connection between the SMV and the IMV. the wire went through. So we basically did a second stick. So this kind of a double stick mesenteric access. The first one was the SMV. We couldn't find our way to the portal vein. The other one is actually the IMV. And now we actually see the portal vein cord. It's a nice direct shot. And that's the caudate lobe there. We know that there's a communication between the IMV and SMV because our wire went there. So we're going to go there and reach the portal vein and open up the mesenteric SMV and IMV towards that, push towards that, get in there with a quick cross, land the tips on a micro snare. The black, that's the wire, the just a safety wire. The micro snare is one orange and in yellow. Land it with a colapinto and a Chiba needle. Grab that 018 wire and pull it in, and now you have that kind of nice C curve. Get your quick cross and down into the main portal vein, and the rest is all, coiling of shunts and angioplasty, repeat angioplasty. This communicates the IMV with the SMV, angioplasty, land your tips down, embolize and/or sclerose varices to force flow towards the portal vein. Seeds, the portal vein is diminutive, but now it's continuous, and it's going to be repeat sequential angioplasties, long angioplasty ballooning for about 2 to 5 minutes, sequentially with larger and larger balloons, and over time it does get better. The key problem with mesenteric recanalization without splenic continuation, or the spleen is out, is that you need flow. The inflow is usually poor. What you want for a transplant is the portal vein to be above 20 centimeters a second. If it's less than 20 centimeters a second, you may get portal vein thrombosis of the transplant. So the key thing is flow. One of the good things to improve flow in mesentery, especially with men with big guts, is to have them eat early after the procedure. If they're hungry, let them eat. That increases the mesenteric flow. The key thing is to improve the inflow and increase the flow to above 20 centimeters a second to maintain a transplant, or to maintain patency if they don't get a transplant of the native portal vein that you opened up with sequential angioplasty. This is the patient after 15 months. There is no spleen in this particular patient, and it just shows you patency. This is repeat angioplasty of the same patient, bringing the patient back again and again. Yes, there's a narrowing, but as things are improving, and bringing them back for repeat angioplasty is a cutting balloon and close surveillance. And this is the same patient. It looks actually a lot better. Yes, there was a narrowing, but it's a lot better than when we first opened it with far less collaterals. Got restenosed again about 2-3 months later, and we angioplastied it as well again, showing you kind of improvement over time. The last thing I'm going to show you is recanalizing through a mesenteric, through the mesenteric tributary, through a ciliotomy. This has largely been abandoned because of percutaneous mesenteric access, but before we did that, what we did was have transplant surgeons actually bring up a piece of mesentery through a mini ciliotomy, access the mesenteric tributary with a 6 or a 7 French sheath, and then go antegrade towards the portal vein and recanalize through that, through a transhepatic access or transtips access. Never sharp dissection. It was always with a glide wire and snare. Capture through the wire, floss right through, and then deploy a bare stent across the mesentery, and then coil embolize competing collaterals to actually maintain patency. This stent stayed open for about 2 years with good flow on this patient. So that's another option to remember. If you can't get percutaneous access and you're unable to recanalize, you can actually do a a hybrid procedure with transplant surgery or hepatobiliary surgery to get a ciliotomy and access the mesenteric tributary to recanalize. So Overall, the primary first line is transsplenic. Second is transhepatic in small spleens or splenectomies. That's your second line. And then in mesenteric discontinuation, where you can't get to the splenic axis. And then your last resort is transmesenteric access with a mini ciliotomy or mini laparotomy as the very last resort of a transmesenteric access instead of percutaneous access. Thank you.
Thank you, Dr. Saad, for the excellent talk. I'll now open it up to questions from the audience. It seems like our first question in the chat is, can you speak about intra-op and post-op anticoagulation strategy for PVR?
If there's cirrhotics and the portal vein flow is above 20 centimeters a second and you shut down the shunts, you don't need to anticoagulate them. If you put stents outside of the tips, stents in the portal vein or in the SMV, which I don't recommend for as a prelude to transplants, then you need to give antiplatelet medication and not anticoagulation. Aspirin and Eliquis would be enough for that. Sorry, aspirin and Plavix would be enough for that. So antiplatelet medication for stents outside of the tips. If the tips is in as a stents, that you don't need to give antiplatelet medication. For coagulopathies, you have to anticoagulate these patients, and it's usually dual anticoagulants. Our primary anticoagulant would be Lovenox therapeutic BID. If the patient cannot afford Lovenox, we've had some of these patients like that, then we would revert to the good old warfarin or Coumadin, make them therapeutic.
Thank you. Does anybody else have any questions? Okay, in the interest of time, I think we're going to move on to our next speaker. Thank you again, Dr. Saad, for the excellent presentation.
Thank you.
Of course. Our next speaker will be Dr. Riaz, and he will be discussing endoscopy in the gallbladder and benign and malignant biliary disease. I invite you to share your screen and then take it away.
Perfect. Thank you so much. Can you guys hear and see my screen?
Yes.
Perfect. So I'm Dr. Riaz, I'm one of the interventional radiology attendings at Northwestern. These are my disclosures. I'd like to start off by saying that I'm very excited that Premal and I are twinning today. So biliary drains, I know we place them a lot in interventional radiology, but we understand that they have a significant impact on the physical and psychological status of a patient. And they have been the limitation of IR management and in biliary disease and gallbladder disease for a very long time. So we all see patients that we put drains in come back with situations like this. They have pericatheter leakage. Their skin becomes red, tender, painful, significant problems with their lifestyle, with the drain in. And then it's one of the things that other services use against us when we are managing biliary strictures and leaks, that you'll have to have a drain after you put it in for a very long time. So we have come up with this mantra at Northwestern. One of our prior fellows, Christopher Hesch, came up with this, no drain left behind, and we follow this very, very strongly. We wrote a paper recently in JVIR last year showing that around 44% of our patients that we put drains in have pericatheter bile leak, which is unacceptable. We have ways to fix it, but it should not happen the first time. And we are trying to figure out what we can do to minimize that. It could be redesigning of the catheters that we put in, but there's a lot of work to be done here. So how can we improve issues with drains? We can do procedures without drains. We can minimize the number of drains. We can minimize the duration the drains have to stay in, and then definitely minimize drain-related discomfort. So, for example, if a patient, and talking about four, if a patient can live without a drain bag, that's less hardware attached to them, and that will significantly improve their quality of life, right? So if you have portability drain in, it should be our aim to try to cap it as quickly as safely possible. So biliary endoscopy, something we do a lot of at Northwestern, showing some images and videos from what we've seen. So bowel, normal bile duct, colon cancer, kind of just in the bile duct, recurrent PSC video on the left part, lower part of the screen, and then ischemic cholangiopathy showing this dusky, bad-looking bile duct with sloughing off casts inside the bile duct, again, post-transplant patient. So endoscopy, in addition to the diagnostic value, we could use it now to actually biopsy transhepatic into the bile duct, take samples of the normal mucosa that we see. We recently wrote an atlas on in the seminars of interventional radiology showing what GI and IR have and what looks abnormal, and then biopsy those areas targeted. And this increases our ability to actually get samples that we need significantly compared to brush biopsies. We've used it to get through existing stents. So this is a patient that had to have a drain replaced for occluded metal stents, but we also can use it to look at what's causing the occlusion inside the stent. Is it tumor or is it debris that is causing this occlusion? So something we do a lot of at Northwestern is percutaneous transjejunal access for biliary interventions. When the surgeons do a Roux-en-Y at Northwestern for transplants, they create a modified Hudson loop where they take the Roux limb, pexy it to the abdominal wall, and put surgical clips. The reason is to be able to do procedures in these patients without sticking their transplanted liver and do procedures without drains at all. So showing a normal ERCP on the left and a patient ERCP who has had a Roux-en-Y on the right. If our Compi or other catheters are taking a couple of turns, it's hard to make them do what they want to once you're where you need to be. So imagine having a gastroenterologist having all of these turns with their scope and trying to do biliary procedures with their scope through such long bowel loops and then having so many turns. So this is much easier, right? So we have the surgical clips shown by this black arrow on the left. We access the bowel. Once we're in the bowel, we can find where the biliary enteric anastomosis is, get the wire up, and once the wire's in, we can let the IR in us take over. Plasty, put stents in, similar to what IR would do. So this is one such example. Imagine trying to find this using just fluoroscopy. You can actually see the abnormal biliary enteric anastomosis. You can't really see any bile going into it when you inject contrast from the bowel side, but then you can focus your wire on that specific area and you see sanguineous bile come out. And once the wire's in, you confirm with X-ray that it looks like it's not just in the peritoneum, and then start doing what you need to do next. This is our mechanism of deploying these stents. These plastic stents have flanges on them, so we deploy them using peel-away sheets. We don't have a percutaneous delivery mechanism for them, so it would be a great addition to our armamentarium to have such devices. So once you put them in, you're also responsible for taking them out because these plastic stents have a median patency of around 2 to 3 months, depending on the size. So the first way we used to take them out was just use a snare, grab the stent and pull it out, similar to how GI would. But then recognize that when you do that, your wire access across whatever the stent was crossing is lost. So now we try to find the end of the stent and guide a wire into the end of the stent and put a balloon over the wire. And that balloon, the 4mm Mustang, for example, grabs the stent from the inside. Now you maintain wire access and pin pull the stent off. So this is another great example of a deceased donor liver transplant who had abnormal liver function tests. Alkaline phosphatase was high. So we went in and grabbed a very strange looking structure that was protruding into the bowel. Once we grabbed it and pulled it out, you can actually see purulent bile come out. And at the bottom, you can see the cast that we were able to take out of the bile duct. And this is a cholangiogram afterwards. So pretty much the whole bile duct was obstructed by a bile cast, showing that this patient probably had some degree of ischemic cholangiopathy during their transplant. So crossing difficult strictures, the scope has definitely helped us get to where we need to be. Converting an external biliary drain to an internal external is something we do a lot of. So this is an example where we were able to get into the right posterior system through the Hudson loop, but were not able to find our way into the right anterior system. So we've got percutaneous access, but again, we're not able to find our way from the percutaneous access into the intestine from the right anterior system. You can see the MR showing the same exact really tight narrowing. So then we placed a snare on the inside and then used a power wire to create a neoanastomosis. As you can see on the image on the left, we have a microcatheter in the artery just to make sure that we didn't burn our way through the artery. And we're also looking with ultrasound to make sure that we were not going through the portal vein when we made this tract. And then this patient did really well because we were able to create a neoanastomosis, convert them to stents, and then eventually take care of them from the inside. This is another example of a patient who had secondary sclerosing cholangitis from a hepatic artery infusion pump. Was an external biliary train was placed in an outside hospital. They tried converting it to an internal external, but couldn't. So we came in. We used the scope. Found this on the right most image on the endoscopic image. You can see this really tiny green dot, and that's where the actual narrowed duct was. We were able to find our wire, get it through that, and then get the wire through, and then using our kind of what I try to teach my fellows is all the branching pattern mostly in our body is fractal. So once you get to one V, you find the next and keep going until you reach the bile duct. And then once you're in the bile duct, you can address the system you're in, but then you can have GI come in and help and put stent into the system that you're not accessing percutaneously, minimizing the number of drains that these patients might need. So combination cases with GI has really helped our ability to minimize number of drains that these patients have. This is an example of a case that we've been doing for a while now. A patient who had hepatolithiasis, no Hudson loop, so we had to go percutaneously get the stones out. But then after, as you can see on image B, that there is still a very persistent stricture. We were able to get a scope in, make sure the stent looked malignant, and then used endobiliary ablation to remodel the anastomosis, and then put the double dragon drain in. The double dragon drain is just a 14 French drain going in. You cut the hub and put an 8 French drain in, and then have it come out the first side hole so that you're prolonged dilating the stricture. And then that's worked for us really well. This helps us minimize the duration of drains that these patients need for a very long time, in some instances for these benign strictures. This is not my idea. This is published in Korea I think 10 or 15 years ago, and we have been able to use this very successfully in our patients. Our benign biliary endobiliary RF ablation data is on this slide, showing a 92% patency at 1 year. We've also used it in the malignant side, especially in-stent strictures. So if you have an in-stent stenosis, you can place your drain. And then in this case, you can see that when you inflate the balloon, there's still space between the initial stent and newly placed stent. And when you put the scope in, you see soft tissue growing into it. You can use RF and restructure that duct. So one thing that we've been doing a lot of now is try to address the contralateral lobe in the side that we're in to minimize the number of drains that these patients might need. So we get in on the right, from the right side, go into the left, use a balloon. We have not been able to put a stent that appropriately drains the left side using this approach, but we're trying to figure out how. But in this case, the patient had a G-tube, so we used that G-tube access to pretty much do an ERCP and then place a stent into the left system and a drain into the right. The pediatric world has a huge role for percutaneous endoscopy. We just did our first endobiliary radiofrequency ablation in that in a kid a couple of weeks ago, and it worked really well. So combined procedures, this is a case of a patient who had a liver transplant, complete stenosis at the hepatic jejunostomy. GI wasn't able to cross independently. We were unable to cross, but then GI came in and served as a target, and we were able to use an RF wire to create a neoanastomosis, and they placed stents, and this patient was drain-free right after this procedure. Gallbladder endoscopy, I'm going to go quick in the interest of time. I know this is very interesting because we can go in now and try to break the stones up, put cystic duct stents in, and remove these patients who have had long-term gallbladder drains. The reason why we're doing a lot of this is basically summarized in the slide, per chole rates, which is putting a drain in the gallbladder rate, have increased by 567% in a 15-year period, while laparoscopic cholecystectomy, where they take the gallbladder out, has only increased by 3%. So we're doing a lot of this. We need to put the drains in, but again, try to figure out how to take them out. We recently published this in Annals of Surgery, by recently meaning the last month, showing that what we were able to create this algorithm on how patients should be dealt with if they're not surgical candidates. A very interesting read. I'm not going to go into details, but if you have a never surgical candidate, you can consider gallbladder drainage from the endoscopic ultrasound side using a lumen-opposing metal stent. But if they're not, then a percutaneous cholecystostomy should be considered, because that is the patient that can go to surgery. A patient who has endoscopic ultrasound guided drainage of the gallbladder cannot. Cystic duct stenting and lithotripsy is something we do a lot of. This is an example where you go in, put a drain in, let the tract mature. If the patient's not a surgical candidate on the follow-up, you bring them back, put a peel away sheath in, break the stones up. It's like playing a video game for a couple of hours. And then you just take the stones, all the stones out, and place double J ureteric stents from the gallbladder to the duodenum. We've also done cystic duct endoscopy now, which we initially weren't able to do, but we figured out how to get a scope into the cystic duct to clean that up and then take care of it. This is an example of an endoscopic ultrasound guided drainage of the gallbladder, which we helped the GI folks because they were unable to see the contracted gallbladder. So we inflated the gallbladder for them, and then they could stick the gallbladder using a percutaneous approach. Using a lot of these cystic duct stents, we've seen these patients get pancreatitis. So this is an important slide. If you have a patient that develops pancreatitis, it's a problem, especially in these already sick patients. So trying to use the GI data that's already out there, rectal indomethacin and Ringer's lactate have significantly decreased our pancreatitis or clinical pancreatitis rates in our population. This is an owl I saw yesterday, so I'm very excited that I was able to see this. Any questions, guys?
Yeah, I had a quick question. As far as what do you quote the patient's recurrence of cholecystitis when you're taking out the gallstones in, say, 5 years or 3 years?
That's a great question. So the data that's out there, we actually have that in our paper that we wrote in Annals of Surgery. It says that if you have a patient with acute calculus cholecystitis, there is around a 20 to 30% recurrent cholecystitis rate in the timeline that you just asked. If you have an acalculous cholecystitis patient, that's a completely different story, right? You have a patient that has acalculous cholecystitis, you have a patent cystic duct, everything looks great, the tract is formed, you can take the drain out, and if everything is great, they would probably never have recurrent cholecystitis just because of that. If they get sick again and they have decreased gallbladder motility, maybe, but you don't need to leave a drain in for that.
Any thoughts on cryoablation?
I am not a big fan of it. I know people have looked at it. The things that kind of make me go away from it is that I am of the camp that you kind of want to open up the cystic duct as much as possible, take the stones out so that they're no longer siniduses of infection. If you do a cryoablation with the gallstones in place, that is completely, I don't understand that concept, right? You have stones in, they continue becoming a nidus of infection. We take care of dropped gallstones all the time where patients develop abscesses due to gallstones being in bellies where they've had difficult cholecystectomies. You're leaving a gallbladder in with stones inside it and then just ablating. That doesn't work. In my view. And then the other thing that I feel would be a problem is if you just cryoablate the gallbladder without taking care of stones, and you have to use 10 probes to do it, I feel that that's also a little too much. There are much easier and safer ways to do this now.
Thank you.
Dr. Rios. Excellent talk. I think it really highlights how innovative and really cool VIR is. In the interest of time, I think we're going to move on to our last speaker of this session. So Dr. Trivedi, welcome. I'm going to invite you to share your screen, and he's going to be discussing balloon-occluded retrograde and antegrade transvenous obliteration.
Hey, thanks so much. Hi, everybody. I want to start by just congratulating the organizers of the symposium. It's really been incredible listening to the speakers. I wish I had something like this when I was a medical student. I think we just keep getting better every year. I also want to put a plug for biliary endoscopy, even though that's not my assigned topic. Dr. Riaz has done an amazing job of summarizing. I think there's a ton of really interesting content in there, worth a second listen, and maybe attend SIR, the deep dive, to learn more. I'm going to talk today about BRTO. Let me attempt to share my desktop. Okay, hang on. We're sharing the wrong one. Stop share. Let me see if I can get us to. PowerPoint. Let me try this. And let me know if you're seeing. Continue to share.
We're seeing your presenter view.
Yeah. I think the best option then is, let me just see if I can flip this. Give me 1 minute, sorry. Okay, let's share this guy. And then, is that working?
Yes.
Okay, great. So let me dispense with the nomenclature first. So we're talking about balloon-occluded retrograde transvenous obliteration of varices, kind of a mouthful. That's BRTO. BATO is the antegrade version of that. And PARTO implies occlusion with a plug, and a CARTO implies occlusion with a coil. I don't think none of that stuff matters, right? It's ultimately, conceptually, what are we doing? Retrograde versus antegrade transvenous obliteration of gastric varices. This is a super interesting topic. It's a little different than your generic portal hypertension related varices. Gastric varices are challenging. They're less frequent. They're associated with higher mortality versus esophageal varices. They have complex venous inflow and outflow, and they tend to occur at lower port systemic gradient. And for that reason, if you make it really simple, amongst the treatment options, endoscopy remains first line, but there's a higher risk of recurrence. TIPS may make sense with certain types of these. Again, recurrence rates are higher than if you look at BRTO. When applied with the correct anatomy, the correct problem, it's incredibly effective. To get into it a little bit, if there's one thing people remember from this talk, it is that everybody needs to understand the inflow and outflow, because the most common reason, we have lots of people who fly to our medical center who have been treated previously, and it's not that the treatment wasn't done well, but it's just that occasionally the failures are related to the treatment not matching the driver, the pathophysiology of the gastric varices. To that end, there's 4 subtypes. This is a Sarin classification. GOV1 is almost, think of them like esophageal varices. These are a result of portal hypertension. They're fed by the left gastric vein, and they can be treated effectively with endoscopy first line. GOV2 is where it's a kind of a global and a regional problem. There's portal hypertension and sometimes additionally significant splenic inflow, so you get these fundal varices. Isolated gastric varices are where, as you can see here, they're really just isolated to the gastric fundus. And the way to think about this is there's a ton of pressure kind of collected regionally in the gastric fundus. And BRTO is indicated when we have fundal varices with a gastrorenal shunt, IGV1 and GOV2, and when you have gastric varices with a baseline situation where TIPS is not safe, right? So there's encephalopathy, decompensation, etc. I want to highlight the work of Dr. Saad here. He's written many great educational resources. I wanted to pull one of his excellent figures here. To understand the anatomy, let's look at inflow. So we've got left gastric. Here's a portal vein, right? Splenic vein, SMV. Everybody's aware of this anatomy. Then you've got inflow through the left gastric, the posterior gastric, and short gastric veins. We're not typically aware of these little things, but they very much relevant to the conversation here. So here's your portal veins backing up, and here's your inflow, right, through all these veins. Then they feed the gastric varices, and outflow is through either a gastrorenal or gastrocaval shunt. What does that mean? Here's the varix being fed by those three things, and then it's draining through. When there's a gastrorenal shunt, it's coming out this way. Gastrocaval, it's going up and into the IVC. And sometimes you have a coexistence of both. Now, I did this very rudimentary, like cartoon figure with a crayon. And this is zoomed in, right? So this is your gastrorenal shunt. It is the inferior phrenic vein that's become patulous and serving to drain all this extra blood. And what I want to highlight here is that there's two components. There's a false varix or an extraluminal varix, and then there's a true varix, which is an intraluminal varix, right? This is where it's in the true, in the stomach. And here's your short gastric and posterior gastric veins feeding it. Bleeding is from the true varix, and it's really important to get it, not just address the false varix. And this is another, I think, common source of failure despite treatment. And to highlight the difference between the two, right, you can see here the extraluminal component and then the intraluminal component. And often there's like a little connection vein between the two. And it's also, if you're going to be in the system, it's important to understand the normal outflow of the inferior phrenic vein. So you've got the intercostal vein. There's many others, but I want to highlight the unusual ones: the hemiazygous vein, pericardiophrenec vein that goes up to the subclavian. And these are all extending above the diaphragm. So if you see veins going up there, that's normal. So how do you do a BRTO? Well, I typically start with common femoral vein access, and you get access into the left renal vein. And then you select the left adrenophrenic confluence. And this is where, right, the adrenal vein and the inferior phrenic split apart. Get, stable access with a wire and catheter in the inferior phrenic vein. And then lots of different options in terms of how to secure that access. If it's a simple system, right, it's a small vein, a balloon occlusion catheter is plenty. You just get it up there. If you can get good balloon occlusion, fantastic. The hardest part of it is that first step. Typically, we'll use a microcatheter to get deep into the varix, and if needed, embolize any collateral drainage. It is typically needed, right, just to denude the system and make it simple enough to do retrograde therapy. The way to think about it, again, conceptually, is this is a complex network. It has multiple inflows and multiple outflows. And if you're going to treat something retrograde fashion through the outflows, you've got to simplify it to as much as possible to get to the variceal network itself. And so you're kind of denuding it ideally to one outflow that you're occluding. That's where the embolization's coming into play. Then you get proximal occlusion, either with a plug or coils. If you do a plug, it's a lot faster. And embolize with combination of STS, Lopidol, sometimes gel foam to thicken things up, and either CO2 or air. So here's an example of a really, I think, a relatively simple BRTO, right? So here's your catheter. We've done the first 3 steps of this thing where we've gotten common femoral vein access, we've selected the left renal vein, and we have the catheter in the adrenophrenic confluence. Well, let's take a look at the normal veins that we're seeing here that we should all be aware of, right? Here's the inferior phrenic. You can kind of see 2 different densities. So the darker density is the beginning of your variceal network, and then the lighter density is all these slightly hypertrophied outflow veins that have been carrying all that extra blood everywhere. And what's interesting is there's a dual outflow here. There's a gastrocable shunt, and then you get your normal, right, the normal efferent drainage veins that we just discussed. Here is a balloon occlusion catheter in this system. Anybody see the varix yet?
No.
Not really, right? And so this is a matter of, well, we're occluding, but we're not getting enough retrograde flow into the variceal network. What we need to do is occlude the competitive outflow, right? So here we are, relatively straightforward in this case, where just taking out the primary channel that fed most of it was enough. And now, right now with occlusion and an injection, we can see the variceal network. I will point out a super important concept here, which is there's the true, right, the false varix and the true varix. So you can kind of see the true varix, it's actually the lighter one. And visualizing that well is really important to make sure that the refluxed embolic material flows all the way in and into the inflow, right? So here's the inflow, here's the short gastric, the posterior gastric. Refluxing all of it into the inflow is important to ensure that the entire network is taken down. And then, we leave once that's done, we can detach the plug. Obviously, if you coiled, that's usually already permanently occluded, and you remove the microcatheter. Very common issues that come up are, I showed you a relatively simple, beautiful example of a single outflow vein. But typically the shunts are large. There's a ton of flow going through them. It is very common to deal with occlusion issues. What's helpful, at least for me, is get a CT and see if there are any particular areas of narrowing that you can target to put in a plug. If it's all just large, you're going to spend some time occluding it. You could do plugs, you can do 2 plugs, you can do lots of coils. Once you get occlusion and you have to have distal enough access with a microcatheter in the variceal network, then you can reflux material into the right place. Competitive shunts, again, kind of related to effective occlusion, can be a lot of work. And understanding normal anatomy here is incredibly important. If you're just sort of walking through the procedure without a strong understanding of anatomy, I think it can get pretty confusing and frustrating. Difficulty assessing endpoints. So, treating half of it is no good. You've got to treat all of it. And so understanding, you got to rotate the II, see the true lumen, understand what the network looks like to begin with, and make sure you reflux into the inflow. Here's an example where we didn't do that, right? This is we had to go antegrade and address a little bit of a non-embolized component through an antegrade TRIPS approach, because we sort of refluxed into probably about 80% of the network and not fully into the inflow, which then leaves an opportunity for that little piece of it to open up, to perforate, and the patient can bleed out. To that end, I like to do a CT scan before they leave with the embolic material sitting there, just to confirm that the entire network is down. That's a whirlwind, a quick one, but lots of little pieces in there. Happy to talk about any of them if we have a little bit of time left.
I think we do have time for a question or two if anybody has any.
So what's your strategy for these larger, have you found success putting 2 plugs side by side at 20 millimeter or greater? That's always a challenge I find. You have to oversize the plug, and you have like gaps in between, and if it's 1-to-1, then it's too big, the holes.
Yeah, no, I mean, the really big ones just end up being, for me, really long cases where it's either a ton of coils or plug-in coils. And yeah, occlusion is a challenge. Occasionally there are little necks and I try to target them intentionally. That's been a real help, is instead of kind of dealing with the venographic anatomy, having a CT understanding of if there's a little area where it's relatively narrow, it's much easier to get focused treatment there. And sometimes it's higher up than we would typically plug or coil. But yeah, that's the biggest challenge, I think, with the procedure.
I have a question. In what patients would you combine possibly like BRTO with TIPS? Like, what's the ideal patient?
Yeah, really great question. So think of it, this is conceptual, right? And it's going to the very first slide. Let me maybe bring it up to help us think of it. So let me share again. So At the risk of sounding really simple, I want you to think about the different types of gastric varices and think about what the inflow and the outflow is. So there's regional flow issues, there's global plus regional, and then there's like isolated flow issues. So what do I mean by that? GOV1, for example, it's portal hypertension and it's resulting in left gastric vein-induced variceal bumping up, right? So that you could treat that like standard things with endoscopy first line. TIPS is going to work pretty well as long as they're a good candidate, right? GOV2 can be typically it's a combination of portal hypertension and tons of inflow from the spleen. So now you got two pumps. One is coming from the liver, one is coming from the spleen. And this is where, if they're a good candidate, I think TIPS can be really effective because you need systemic control, right? What you're not doing with a BRTO is systemic control. You're doing regional control, and all that extra blood is going back into the portal vein, and it's going to go off somewhere. So I would say if this is a patient that has a global portal hypertensive problem and that can be addressed safely, we should do that with a TIPS plus minus a variceal obliteration to treat with regional varices. Think of the spleen as a pump in this situation and also think about addressing that. We didn't really talk about, quote, splenectomy, but really partial splenic embolization. It's an incredibly effective adjunct therapy to ensure that there's a durable response to regional flow problems. If it's a truly isolated issue without not like a non-cirrhotic, for example, or someone that's got obviously you could have portal hypertension, but it's not safe to do a TIPS because of encephalopathy or significant decompensation, then you just focus on spot treatment. I hope that kind of conceptually makes sense.
That definitely does. And thank you, Dr. Trivedi, for the excellent talk. I think there are a couple questions in the chat if you wouldn't mind staying by to answer that. I think Martin asked one, but we will be moving on to our next section, and I will welcome Hunter to introduce our speakers.
Yeah, help me with the question, sorry.